So now we're going to talk about delivery planning and how to counsel women who've had an obstetric anal sphincter injury about what to do in their next pregnancy. So we're going to review the existing literature, review the guidelines, and then tackle the gray zone. So when you look at large cohorts of women who've had an obstetric anal sphincter injury and then have had a subsequent delivery, the majority of them deliver vaginally. So this is a cohort in the US of about 750 women, and you can see that 88% of them delivered via spontaneous vaginal delivery, 2% delivered via operative vaginal delivery, and 10% delivered via C-section. So 90% delivered via vaginal delivery after a prior obstetric anal sphincter injury. And in that group, 16% had a fourth degree versus 9% had a third degree. When you looked at that group of women who had C-sections, the reason for C-section was elective in 32% of them. So there were 73 women who opted for a C-section, and 23 of those women had an elective reason. Macrosomia or a prior shoulder dystocia accounted for about 17%. And all of the things that are any variation of blue in this pie chart are something related to their obstetric anal sphincter injury as the reason that they wanted to have a C-section. So when people have a C-section after an OASIS, it's often related to the OASIS. So in this cohort of 90% of women who had a prior sphincter injury who underwent a vaginal delivery, 85% of them had a first or second degree laceration in their next delivery, and 3% had another OASIS. So, you know, the vast majority of women who had an obstetric anal sphincter injury in their first pregnancy, if they have a vaginal birth the second time around, they're not going to have another OASIS. Of those who had an OASIS, 96% were third degrees, and only one woman had a fourth degree. Factors associated with a second OASIS included mediolateral episiotomy in the index delivery, so the first pregnancy, and the use of chromic suture for OASIS repair, which I don't know. Do you guys use chromic? Does anybody use chromic? Yeah. And then in the subsequent delivery, having forceps delivery significantly increased your risk of having another OASIS, and having birth weight greater than 4 kilograms. This is actually, I'm going to talk about this slide in a minute. So this is a retrospective cohort of almost 1,200 Australian women with OASIS and a documented subsequent delivery. And again, you see that about 90% underwent a vaginal delivery, and about 10% underwent a C-section either with or without labor. And in this group, when you looked at them, the risk of subsequent OASIS in the next delivery was not statistically significantly increased, which is not really surprising, right? If the risk is only 3%, then it's not statistically significantly increased. So these authors concluded that primiparous women who experienced OASIS were less likely to have a subsequent baby, more likely to have a related surgical procedure in the 12 months postpartum, and no more likely to have an operative vaginal delivery or an OASIS in a subsequent birth. In another study looking at bowel dysfunction 3 to 8 years after obstetric anal sphincter injury, they asked women their thoughts about subsequent deliveries, and 33% of women who'd had obstetric anal sphincter injury wished to postpone subsequent delivery, 18% wished to abandon plans for having more children, but 59% had another baby anyway. So regardless of what they thought, they ended up, even if they had reservations, most women are going to deliver again. So we should probably figure out how to help them figure out what makes sense for them. 49% of these women had a C-section for their subsequent delivery, and 3 out of 38 with the vaginal delivery had OASIS in the case group versus 5 out of 26 in the C-section group. So the risk of OASIS was highest in the C-section group. This is a UK study looking at OASIS bowel symptoms and quality of life after prior OASIS. So there were 59, this is a series of 59 deliveries, of whom 12 women were recommended to have a C-section. Of those, 3 declined a C-section. So a total of 50 women attempted vaginal delivery, and 9 women had a planned scheduled C-section. Of the women who were planning vaginal delivery, a number ended up having, 5 ended up requesting a C-section, and 4 ended up having an emergency C-section. So there were 41 vaginal deliveries out of the 59 deliveries with an OASIS in the index pregnancy. And of these, only 3 had a repeat OASIS, and the majority had just a vaginal delivery without a repeat OASIS. So the risk of OASIS in this study was 7% with a subsequent vaginal birth. So again, much higher than the risk of OASIS that we quote in the first time. But overall, their chances are much better of not having an OASIS in their second vaginal delivery than of having an OASIS. And then we've already learned a little bit about anorectal manometry and what happens to women, Paris women, every Paris woman will have a different anorectal manometry after having a vaginal delivery. But among women who had a prior OASIS who delivered in a subsequent pregnancy via the recommended mode of delivery, maximum squeeze pressures were lower after vaginal birth, but did not change after C-section. So probably the damage that happens the damage to the anorectal manometry findings that happens as a result of vaginal birth can be prevented with C-section. However, the bowel symptoms didn't really change in this group at all. So the authors concluded that women who had no antenatal evidence of objective compromise of anal sphincter function could be reassured that a vaginal delivery was not associated with any significant deterioration, or in function or quality of life. And then the last study I wanted to touch on is a decision analysis, which is a theoretical cohort of over 75,000 women with a prior obstetric anal sphincter injury, using a software called Triage to inform an analytic decision model comparing elective C-section with trial of labor after anal sphincter injury. This was a US study. And basically with a decision analysis, you vary the potential risks and benefits to find the tipping point of when things make sense. So when you varied the duration of fecal incontinence up to just over 5 years, it favored a trial of labor. Versus varying the duration of fecal incontinence in women who had a repeat OASIS, varied a trial of labor to 4.5 years. So these authors concluded that women with a history of OASIS experience more postpartum urinary incontinence and fecal incontinence, but the burden of postpartum incontinence is high in general, and C-section is not entirely protective, sadly. But we're somewhat limited by the fact that bowel symptoms actually happen decades later. So we don't know which of the women who had an obstetric anal sphincter injury with their pregnancy 2 years ago are going to be the women who have significant impairment when they're 60. So the evidence doesn't really tell us what to tell our patients, which is where we look to expert opinion rather than evidence-based opinion. And so ARCOG says that all women who have sustained an anal sphincter injury in a previous pregnancy should be counseled about the risk of developing anal incontinence or worsening symptoms with subsequent vaginal delivery. They should be advised that there's no evidence to support the role of prophylactic episiotomy. And if they're symptomatic or have abnormal ultrasound findings or manometry findings, they should have the option of elective cesarean birth. ACOG the American College does not make a similarly strong recommendation, and they essentially say that cesarean delivery on maternal request should be discouraged in the absence of any maternal or fetal indications. But they don't say that you can't do it. They just say that you should try to encourage women to have vaginal birth. ACOG does not list anorectal dysfunction as a condition for which C-section is favored. And the NIH says that limiting the use of midline episiotomy and forceps can reduce the frequency of OASIS, and acknowledges that there is an association between OASIS and fecal incontinence. But it's hard to show that you can reduce the risk of anal incontinence with a planned C-section versus an unplanned C-section versus instrumental vaginal birth. The question of prophylactic episiotomy is a sort of controversial one, and people tend to be pretty committed to their opinions about this issue. But what this study concluded was that if you're going to do an operative vaginal delivery, you should cut a mediolateral episiotomy to reduce the incidence of OASIS. So not a midline episiotomy, which is going to increase your risk of OASIS, but a mediolateral episiotomy. If you're going to put forceps on a baby, you know that you're increasing their risk, the person's risk of obstetric anal sphincter injury. So cut a mediolateral episiotomy to try to prevent that from happening. A 2010 Cochrane review says no benefit can be demonstrated for cesarean delivery over vaginal delivery in the prevention of anal incontinence. But obviously there are no randomized studies comparing cesarean delivery to vaginal delivery in average risk pregnancies. So we don't have great evidence. So this is where it comes down to the gray zone, and it's not one size fits all, and there's no easy way to say what we need to do here. So communicating with patients is really key. And the good thing is that pregnancy is 9 months, so you have time to have these conversations with a patient and I see a lot of patients who come to me early in their pregnancy to talk about it and then come to me again when they're 32 weeks or so and they're starting to realize they're going to have to deliver soon and they want to talk more about it, and that's fine. So you want to find out what their preferences are. Do they want a C-section? Are they really motivated to have a vaginal delivery? Because that's going to impact how you reassure them. Did they have bowel symptoms after their last OASIS? Are they having bowel symptoms in this pregnancy? Do they have bowel symptoms currently? Objective assessment of sphincter anatomy and function can help you, as can estimated fetal weight, their future childbearing plans. If they're planning to have 7 children, you don't want to recommend a C-section because that's going to increase their risk of abnormal placentation as they get down the road with subsequent cesarean deliveries. Do they have medical comorbidities that make one decision smarter than the other? And then documentation, that you talk to them about these things, because less is more with a patient. Talk about one issue at one visit and then talk about another issue at another visit. Don't overwhelm them with everything at once, because when they leave they can't remember all the things. I mean, we can't even remember all the things we talked about, but for them it's even harder. And that's it.